Well, the need for new combination therapies in relapsed refractory myeloma is best explained by understanding that now, as most patients receive lenalidomide-based therapy up front, be it in combination with a proteasome inhibitor or other combinations, followed then by a consolidation strategy and maintenance, we now have to know how combination regimens perform when lenalidomide therapy has failed. So in other words, patients who've been on prior lenalidomide or are refractory to it, what best combinations offer best outcome in first relapse and beyond. And in that regard, a number of strategies have emerged. The most important ones that are emerging are combinations that can overdrive lenalidomide resistance. And we have a number of clues. Pomalidomide-based treatment is clearly a forerunner in that regard because the original approval for it in relapsed refractory disease was in patients who had prior lenalidomide exposure and proteasome inhibitor experiences, and they were progressing on those combinations. So as a result of that, we were able to then conjecture that if you brought it earlier into the disease relapse, would it perform as well or if not better? And we had phase 1-2 experiences with the combination of pomalidomide and a proteasome inhibitor, be it bortezomib, ixazomib or carfilzomib, to illustrate that this combination was highly active. So the intent of the OPTIMISMM trial was to look at a real-world combination that could be used not only within the United States but outside of it, and provide patients with the best outcome after prior lenalidomide exposure. So we looked at the combination of pomalidomide, bortezomib and dexamethasone compared to bortezomib and dexamethasone as a viable control in patients who had prior lenalidomide treatment. They could have been either exposed to lenalidomide for a meaningful period, or they could actually be lenalidomide refractory. And in our trial, which is approximately 600 patients strong, we were able to treat everyone who'd had prior lenalidomide, but most importantly, 70% of the patients were actually refractory to lenalidomide. So we really were able to ask the question, what is the best combination in that setting in the context of this trial? And we found that actually a progression-free survival advantage was there for the 3 drugs over the 2. The median was around 4 months with a relatively early look. But what was particularly striking, Steve, is when we looked at the early relapses, the first relapses, that combination resulted in a progression-free survival benefit of 10 months. And that was surprising to us and much bigger than we expected. The study design was a randomized phase 3 with 1 to 3 prior regimens. All patients had to be lenalidomide exposed, as I mentioned, or lenalidomide refractory. The combination for the experimental arm was pomalidomide at a dose of 4 milligrams, 2 weeks on, 1 week off, and bortezomib given according to the standard schedule, days 1, 4, 8, and 11. Dexamethasone was given at a dose of 20 milligrams on the day of bortezomib and the day after for patients under the age of 75. And for patients over the age of 75, it was half that dose. Now, an important part of the regimen, Steve, was it was continuous. In other words, patients got up to 9 cycles of induction remission therapy and then continued on a maintenance as part of continuous treatment. That applied to both arms. And that's very important because in some other phase 3 trials, not only have there been very limited exposure to lenalidomide, but they've been typically fixed duration of exposures. And I think that's not reflective of real-world practice. Real-world practice now involves continuous treatment, be it maintenance or continuous therapy and relapse. And so this reflected that by, in both arms, allowing patients to continue on treatment until progression and or intolerance. So it really provided equipoise in both arms, most importantly for our patients, and at the same time could give clinicians a comfort zone that this was a real-world type of approach. Well, in terms of the efficacy, what was clear when we took an early look was that the progression-free survival benefit to the 3 drugs over the 2 was highly significant at about 4 months, clinically important, and the hazard ratio was encouraging as well at around 0.65. What was particularly striking to us is that when you looked at the first relapse population, the progression-free survival benefit was around 10 months with a hazard ratio of 0.5. And that was reflected by the response rates, where they were in excess of 90% for the 3 drugs versus about 50% for the 2 drugs. So that really was a big difference in favor of the 3-drug platform, and we were encouraged by that. In terms of future combinations, what we feel is that this particular platform of pomalidomide, bortezomib and dexamethasone gives a sort of real-world value proposition, for want of a better term, for the combination of the three drugs, to which you can then rationally add monoclonal antibodies and other treatment strategies. I think important as a principle is it also illustrates that other proteasome inhibitor-based combinations obviously show great promise as well. We know that pomalidomide plus carfilzomib, for example, is very active. We know that pomalidomide plus ixazomib is similarly very active. So all of these combination strategies can be helpful to our patients in respective settings. But I would stress that I think it's a three-drug platform to which you can rationally add new drugs. And the reason I use the term value is because obviously we've got to realize that these 4 or 5 drug combinations we're developing could be potentially very expensive, and we have to think in terms of what are rational combinations for our providers that they can use in the clinic on a day-to-day basis.